Coronary no-reflow phenomenon is a clinical condition characterized by inadequate myocardial perfusion through a given segment of the coronary circulation without evidence of mechanical obstruction in the epicardial vessel. It is most frequently encountered during primary percutaneous intervention for ST segment elevation myocardial infarction. The etiology is multifactorial and often described as a combination of four distinct processes: distal embolization, migration of plaque fragments, fibrin, platelet aggregates from the culprit lesion into the microvasculature during balloon inflation or stent deployment, ischemia reperfusion injury, damage caused by the sudden restoration of blood flow leading to the production of reactive oxygen species, calcium overload, and the opening of the mitochondrial permeability transition pore. Microvascular damage, structural injury to the endothelial cells resulting in blubbing, swelling, and reduced vessel lumen. This is often exacerbated by neutrophil infiltration and capillary plugging. Individual susceptibility, predisposing factors such as hypercholesterolemia, diabetes, and the duration of pre-hospital ischemia. No-reflow is typically identified in the cardiac catheterization lab using the following criteria. 1. Angiographic indicators. TIMI flow grade, a grade 0, 1 or 2 despite the absence of an epicardial dissection, spasm or residual stenosis. Myocardial blush grade, a qualitative assessment of myocardial opacification. Myocardial blush grade 0 or 1 indicates significant microvascular obstruction. ECG findings: ST segment resolution, failure of the ST segment to resolve by more than 70% within 60 to 90 minutes post reperfusion suggests impaired microvascular flow. 3. Advanced imaging. Cardiac MRI, considered the gold standard for identifying microvascular obstruction, visualized as a dark hypo-enhanced core within the hyper-enhanced infarcted area on late gadolinium enhancement images. Pharmacological interventions. Intracoronary administration is generally preferred over intravenous routes to achieve higher local concentration. Adenosine, a potent vasodilator, acts on A2 receptors to reduce microvascular resistance. Verapamil or diltiazem, effective in reducing microvascular spasm. Nitroprusside, an endothelium independent vasodilator and nitric oxide donor. Nicardipine, often used due to its high selectivity for arterial smooth muscle. Glycoprotein 2B3A inhibitors such as apixaban or tirofiban to address the thrombotic component. Mechanical interventions. Aspiration thrombectomy. While once routine, current guidelines do not recommend routine manual thrombectomy, though it may be considered in cases of high thrombus burden. Distal protection devices, primarily used in saphenous vein graft interventions to capture embolic debris, though they have shown limited benefit in native coronary arteries during STEMI. The occurrence of no-reflow is a strong independent predictor of adverse outcomes. It is associated with increased infarct size, reduced left ventricular ejection fraction, higher rates of malignant arrhythmias and heart failure, and increased short and long-term mortality. While intracoronary route offers a physiological advantage by achieving higher local drug concentrations and greater receptor occupancy at the microvascular level, large-scale evidence for clinical endpoint superiority remains nuanced across different drug classes. Vasodilators, epinephrine, verapamil, adenosine. Recent network meta-analysis have shifted the preference towards intracoronary epinephrine and verapamil for acute flow restoration. Intracoronary epinephrine versus adenosine. The quad trial and subsequent meta-analysis demonstrated that intracoronary epinephrine is significantly more effective than intracoronary adenosine in achieving final TIMI-3 flow in normotensive patients. Direct efficacy. A 2025 network meta-analysis of 1,674 patients found that intracoronary epinephrine and intracoronary verapamil were associated with significantly higher odds of achieving TIMI-3 flow compared to control groups. ST resolution. While intracoronary adenosine remains effective for improving ST segment resolution, its efficacy in restoring epicardial TIMI flow appears lower than that of epinephrine or verapamil. The route of administration for glycoprotein 2B3A inhibitors remains a point of clinical debate with a focus on local thrombus resolution. Intracoronary versus intravenous apixaban. Pooled individual patient data from randomized trials indicate that intracoronary apixaban does not significantly improve TIMI-3 flow or 30-day mortality compared to intravenous route. However, it does significantly improve myocardial blush grade. Intracoronary tirofiban. A 2026 randomized controlled study found that intracoronary tirofiban significantly reduced the incidence of no-reflow and decreased in-hospital MACE compared to placebo, though it increased minor bleeding risk. Low-dose fibrinolytics. The use of intracoronary fibrinolytics is emerging as a niche strategy for dissolving microvascular thrombi that vasodilators cannot address. Evidence suggests that selectively delivering approximately 20% of the systemic dose of a fibrinolytic like alteplase or pro-urokinase via the intracoronary route before PCI may ameliorate the burden of microvascular thrombus. The T-time trial showed no benefit for unselected STEMI patients. In patients presenting with ST segment elevation myocardial infarction and an ischemic time more than 4 to 6 hours, adjunctive treatment with low-dose intracoronary alteplase during primary PCI was associated with increased microvascular obstruction. Intracoronary alteplase may be harmful for this subgroup, that is those who are presenting beyond 4 and less than 6 hours. Here is a comparison between the two routes. Local concentration is extremely high, that is 10 to 100 times systemic for intracoronary administration. Intravenous, it is moderate and it is basically systemic. Onset of action immediate at the target site, while in intravenous it is delayed by the circulation time. Systemic side effects: hypotension for nitroprusside and adenosine, potential for local arrhythmias for intracoronary epinephrine. Clinical verdict: intracoronary is preferred for acute laboratory rescue, while intravenous is preferred for upstream cooling of lesions. Ongoing trials such as the EPIVA comparing the combination of intracoronary epinephrine and verapamil against monotherapy are expected to provide further clarity on standardized pharmacological cocktails for refractory cases.